want it to be as available to as many people as possible, right? That's part of reducing stigma and moving forward together. So we'll start recording the meeting now as I once again say good morning. Welcome to Healthy Athens. As you all know, this conversation space is all about increasing supports for people living in recovery and dealing with substance use disorders. And we have been in this either actual or virtual room together for a while now, and there's a lot that has moved forward and still more work to do. So I'm really excited to be in the space with you once again. John, I believe next on the agenda is an update on the needs assessment. Is that correct?
That is correct.
Okay, and I see we have Megan with us today. Megan, would you like to provide that update?
Yeah, absolutely. So we are really happy to report that we have exceeded our goal of 75 providers. We've heard from over 100. We sort of going along with what you were talking about with security, I had kind of one of my highest highs. We thought we had almost 500 responses, but it turns out we had been hacked. So that was disappointing, but still over 100, which is fantastic. So yeah, check if you do surveys, check where those IP addresses are coming from. We had a bunch of people, not even in the United States, trying to get those Starbucks gift cards. So, but yeah, the responses have been great. People have been answering every single question. A lot of them have said, don't even bother giving us the $10 gift card. We just want to help you with info. So we're very pleased, and we're really excited to be able to have a bunch of important data to share with everyone.
Fantastic. Megan, can you, just in case someone is new to this particular assessment, would you mind to make the connection for the group regarding what the purpose of it is, who should be completing it, and then maybe drop a link to that in the chat box for us?
Yeah, absolutely. So this is a behavioral health community needs assessment. This is, these are questions looking at the provider side of supplying resources, specifically what has changed in availability and in clientele between pre and sort of this intra-COVID period. So anyone who provides any sort of behavioral health resources, you're welcome to fill this out. It's about 66 questions. It takes about 20 minutes to complete. There are topics from sort of how you telehealth, COVID plans, safety mechanisms. There are a number of different things. We always try and tell people if there's a question that doesn't necessarily apply to what you're doing, that's totally fine. Just skip it. Not everything's going to apply to everybody. We want as many perspectives as possible. So yeah, it's all sort of under the umbrella of the Resilient Georgia plan. It's the 17 county service area. I'm trying to think what I'm leaving out.
I think that's a great overview. That's perfect. Yeah, thank
you.
you.
Have any questions or anything like that?
So
I have a question.
Oh yeah, go for it. Mm-hmm.
Hey, Megan, great to see you.
Hey, you too.
I received the survey and filled it out to the best of my ability. However, there were a lot of specific questions about bed availability and how our services have been affected by COVID in different departments. And so my question is, has that been sent to other people in my agency, or does the onus fall on me to find that information or to pass the survey on to someone else? And is there a problem with duplications?
Duplications within an organization, not a problem at all. We're expecting that. We're hoping for that because different people are going to have different levels of knowledge and different perspectives. We have distributed to our listserv. It's gone out on a couple of newsletters. So I don't want anyone to feel like it's their duty to forward by any means. However, If the worst thing that happens is somebody gets pinged who's already done it, that's probably not bad. So if there's anyone who you think has a different perspective, can provide other types of information, please feel free to forward. The only thing I'll say is if you were invited in the original link from Grace, that's a specific email survey sort of link, so somebody else wouldn't be able to fill it out. So I'm going to provide a link to the survey that's a universal link. So that'll be the one that's shareable. Does that answer your question?
Thank you.
Yeah.
Megan, thanks so much. You all know, maybe a couple of you haven't been on this call in a while, so I should mention that Resilient Georgia and the Patulik Foundation have funded a great deal of work this year in increasing our opportunity to become more trauma-informed care. I think most of us attended the May training with Dr. Brian Bride. About 450 plus people attended that opportunity. The SBIRT training, screening, brief intervention, referral to treatment, that all was funded through this partnership between Athens Wellbeing Project, Envision Athens, and the Athens Area Community Foundation from those two sources. That's a lot of words, but that's kind of where this is coming from, with the thinking being we cannot accurately or cohesively resolve the gaps that exist in this continuum of care unless we have solid insight into what those gaps are and what the level of provision is. So anywhere and everywhere you can share that link and participate will increase our understanding so that we can hopefully work together to address gaps to services next year. All right, Megan, thank you so much. So next, moving on in our agenda, thank you for joining. If you just signed in, you're in Healthy Athens, just making sure everybody's in the right room. I only see names I recognize, which is a good sign. So next, we're moving on to a conversation that I am really excited about. We have Alan McCorkle, who is a regular, and Brooke and Riley, who are no strangers, I think, to many of you. They are each, I would say, heroes and sheroes in the recovery community for different reasons. I know Allie kind of most relevant to my experience with Healthy Athens as my Narcan person. So she's kind of my local authority for all things related to Narcan and naloxone. And she has been an excellent resource for the behavioral health community through her work with the Georgia Overdose Prevention Council. Did I get that right, Allie?
Yes.
You have
Georgia
a lot
Overdose
of titles
Prevention.
and affiliations,
Mhm.
so I won't try to get them all. But today, Allie and Riley and Brooke are going to share with us a presentation related to harm reduction. So I'm going to turn it over to Allie, and John is going to share their presentation on screen. So thanks so much, guys.
All right. Thank you, Erin. We're really excited to be able to finally share with everybody what we've been working on for well over the past year. So all of Brooke, myself, and Riley, we've all worked in medication-assisted treatment programs for forever. And we've seen kind of the need in our community for so many years. Like many of you, we are kind of seeing infectious disease rates skyrocket right now. So we think this is probably the best time to kind of introduce harm reduction signed into law, that syringe services can be legal, so we can run above board. Really, we're going to spend, I guess, about 10 minutes or so and kind of tell you guys what we're doing 2 nights a week. We want this to be really interactive, so if you guys have any questions, please just raise your hand, type it into the, did you want to say anything, wave anything out? Can y'all hear me?
Allie, the audio is slowing down and speeding up.
Okay. How is it now?
That's better. And if it's glitchy again, I'll send you a chat, and you might want to turn your video off. Though your hair is fabulous, that will help us hear you if all else fails.
Okay. Did you
You're
miss
good for
out
now.
most of that or just the very end of it?
I think we got most of it, so just keep going. And if it slows down again, I'll shoot you a chat and you can just turn video off.
Okay, I just wanted to introduce Brooke and Riley. So Brooke, you're welcome to say good morning, say anything, or we can go ahead and let Riley just move on with the slides.
Yeah, good morning, everyone. As Ali said, we've been working on this project for well over a year, and it really is a passion project for the three of us. And it's actually come to fruition. Like, we're offering services right now, and we're really, really excited about it. But yeah, I'm Brooke. I think most of you know me from these meetings, so no formal introduction necessary. So yeah, Riley, if you want to go ahead, be my guest.
Awesome. Yeah. And thank you all for giving us this platform and letting us share about this. Again, just like Brooke said, this is a passion project, and I don't know how much could be heard from Allie, but like the hepatitis C rates are skyrocketing in our community right now. And that's, this is the kind of stuff that we're trying to tackle. So essentially, we're just gonna do a hard and fast education around harm reduction and syringe service programs and what those are, what that means, and what we do. And John's gonna help me here with the slides. You wanna change the slide, John? Awesome. So what is harm reduction? It's a set of practices and principles surrounding drug use and often sex work put in place in order to reduce the amount of harm done to people and to their surrounding communities. Harm reduction is also a movement for social justice built on a belief in and respect for the rights and dignity of people who use drugs. Essentially, just treating them as people instead of criminals or offenders, as we often do, especially with criminalizing substance use. Harm reduction does not attempt to punish people into recovery and does not give ultimatums. It is a person-first approach, and I'll talk a little more about that with our languaging and messaging. And often it just looks like radical acceptance, compassion, love, and support, no matter what. Go ahead, John. Just some more stuff on harm reduction. It's a set of practical strategies and ideas that are also aimed at reducing the public health risks associated with drug use, just how we were just talking about hepatitis C rates skyrocketing. Harm reduction calls for the non-judgmental, non-coercive provision of services and resources to assist people who use drugs and the communities in which they live in order to assist them in reducing harm. Harm reduction is not the opposite of recovery. People think this sometimes. It's not. It is one pathway of many, and it's just a more patient and sustainable route for many people. It is an approach to treating those with substance use disorders that does not require patients to commit themselves to complete abstinence before treatment begins. Instead, an array of practical strategies are deployed to reduce the negative health and social consequences of substance use. It aims to change behavior according to the goals of each person. Whether that means moderation of use or complete abstinence, it doesn't matter. In harm reduction, complete abstinence is a choice to be made by the person, but not a condition imposed by any treatment program or by us. A basic tenet of harm reduction is respect for patients and their capacity to change. Go ahead and flip that over, John. How can harm reduction help? It gives people more options. There's often less resistance to change from the person engaging with services. It gives those in need a voice, and we listen to them very much all throughout services. There's less judgment with harm reduction. Safe consumption and needle exchange programs dramatically reduce infectious disease, overdose rates, and help those who wish into a recovery pathway. And it dramatically lowers the financial cost to communities. That's a big one. Harm reduction meets people where they're at, but it does not leave them there. And we predominantly work with active users, active IV drug users. Go ahead and flip it, John. So what are syringe service programs? And this is kind of some new language. It's usually like syringe service programs, SSPs or SEPs, syringe exchange programs. And that's what needle exchange, like I knew them as needle exchange programs for 20, 25 years. So syringe service programs are programs that allow injection drug users to trade their dirty, already used syringes for brand new clean syringes. This massively decreases infection rates of HIV, hepatitis C, endocarditis, and abscesses, just to name a few. Those are the most frequent ones. It also helps to keep dirty syringes off the streets and sidewalks. It prevents needle sticks to police and healthcare workers, and people who use drugs can also learn about many other services at the same time, and that's the big one. Drug users who access syringe service programs are 5 times more likely to receive treatment for substance use disorders. And that is huge. 5 times, like essentially we're connecting with a population that does not reach out for services for many reasons, but being able to be a warm handoff for other programs is huge. Go ahead and flip, John. This is both a frequently asked question and just something that I think is, you would think that doing this work would do. But people frequently ask, won't giving drug users clean needles just encourage them to use more drugs? And no, it does not. No research, not only has research not shown that, it has shown the opposite. And it doesn't encourage them to use more drugs, but it does encourage them to use the drugs that they're already using more safely. And while we wholeheartedly support substance abuse prevention and treatment efforts, we know that the most effective way to prevent the spread of HIV or hepatitis C is to stop it at its source, which is the needle. By meeting drug users where they're at in the spectrum of their use and even their recovery, we encourage any positive changes that our participants are ready and able to make. We know our participants care about their lives and their well-being, and we strive to provide the knowledge, tools, and support they need to make safer and healthier decisions. And that any positive changes, that's very common language in harm reduction, as is better is better, where we focus on little tiny steps. We use motivational interviewing a lot also, and essentially just cheer them on even with the smallest positive change. That's really a big deal. And so many programs, because they're abstinence based, it's this black or white, all or nothing kind of thing that I think it seems to be very scary for a lot of active users. Let's go ahead and roll that, next one. So just a little more about syringe service programs. They are associated with an estimated 50% reduction in HIV and hepatitis C incidence. But when combined with medications that treat opioid dependence, also known as medication-assisted treatment, hepatitis C and HIV transmission is reduced by over 2/3. SSPs serve as a bridge to other health services, including HCV, which is hepatitis C, and HIV testing and treatment, and medication-assisted treatment for opioid use disorder. So essentially what that means is getting active IV drug users who are not engaging in safe behaviors engaged with harm reduction, giving them access to a syringe service program until they stop using, getting them into medication-assisted treatment programs, which is like methadone, buprenorphine, it reduces those rates by over 2/3. And I know most of us who do this work, those are really big numbers. Those are just huge statistics. So, you know, in the last, I mean, harm reduction services got big in the 80s with the AIDS epidemic. And it's been like a really hard and fast movement. But there has been so much research done, and the numbers are just incredible by means of its efficacy. So go ahead and roll, John, to the next slide. Okay, so what does Access Point do? Essentially, we hold a safe, non-judgmental space for people who use drugs in our area. We offer everything from safe injection equipment to peer supports, education, advocacy, and recovery resources. We network and collaborate with virtually every other program in the greater Athens-Clarke County area. And we offer recovery supports in many different forms, from abstinence-based recovery to medication-assisted treatment to simply listening to someone who may be struggling. Access Point is harm reduction, and harm reduction saves lives. And again, we really we have the information and the tools, but what we do is we let them decide, and we support them in whatever direction that they want to move in. And that could be anything, but it's very much like patient-centered, person-first motivation, essentially. Go ahead and flip to the next one, John. So Access Point, these are just some things that come of it. We allow people to show up just as they are. They're loved and supported no matter where they are in their use and or the recovery. Support is never conditional here. And what that means is, you know, we will never not serve someone because they're using or because there are behaviors that we deem as unacceptable. That's not a thing. We understand that it costs approximately $400,000 for a lifetime of healthcare for someone living with HIV/AIDS, rather than 30 cents approximately for a clean syringe. And I mean, those numbers are just huge. So it makes a huge positive impact on the community also, and taxpayers' money. Access Point has the ability to educate on a variety of topics, both in the community and with people who use drugs. We use motivational interviewing and acknowledge that the person in front of us is their own best expert on their lives. We never try to force or coerce someone to, I can't see that. We never try to coerce or force someone to change in a way that they're not ready for. And essentially, so many programs do that where you have to, the person has to be willing to essentially kind of be poured into a mold of the program. And we so often see that people aren't willing or ready or able to do that. And so the alternative is they just get no resources at all. And essentially, we want to offer them resources anyway, regardless. So go ahead and go to the next one, John. We kind of talked about this a little in the beginning, but this is us essentially. Allie, Brooke, and I are the board. We have volunteers. We do volunteer trainings about quarterly. So people that are like boots on the ground, so to speak, are volunteers also. And we started this essentially when the laws changed for the state of Georgia, making syringe services legal. Essentially everything that we're doing is 100% legal and supported by the government. I was going to say community, but we're still edging there. Yeah, so go ahead and go to the next one, John.
Well, I want to say something real quick. You were talking about SSPs becoming legal. That legislation came from here in Athens, from Houston Gaines. So that's another demonstration of you know, how our community is, super progressive, and that's, that's really cool. And yeah, we're proud of that.
Yeah.
That's all.
That's 100% true. And I've been really like felt surprised and also really proud of the people who have been supporting these efforts, like coming from people that I wouldn't expect, and different, just like both sides of the aisle coming together for bills like these. And it just, I feel really happy and grateful that that's happening. But so now it's just like the people to come together to do it, which is what we're doing. So here, like, and I just really want to say, if anybody wants to reach out to us afterwards or outside of here, I can give you information and flyers that you can give to your patients or clients to either get them there if you want more education or naloxone trainings or anything that we've talked about. Reach out to us. We have it looks like Allie just put in the chat our email, our Gmail account. We have a website, Access Point. What is our website? Access Point GA.
I put that in the chat box too, so they've got that.
Awesome. But please reach out to us. And again, these are the services that we offer, and we'd love to collaborate. And please do reach out if you have any questions, comments, concerns, anything. We would love to connect and collaborate with you.
Yeah, and as the slide says, I mean, we'll be out there tonight.
Yep. Yeah. At Divas Who Win, who has been a huge supporter and help with our harm reduction efforts. Yeah. They've been awesome. Mm-hmm. Okay, I'm looking at the time and I went significantly over, so
that's
we'll
good.
pass the torch back.
That's good. We always put a buffer in, Riley, just like seasoned facilitators are known to do. So we're good. And this is one of the most important topics that we could discuss. And, this group has spent some, I think, considerable time talking about medicated assisted treatment, MAT, and then naloxone. We haven't spoken as much about the harm reduction strategies, including the syringe support. And so actually next on our agenda is diving into more discussion about naloxone. Before we go there, I'm interested in, within Access Point, do you have some specific measurable goals related to other harm reduction strategies that you would like our group to support you in?
Well, and that's a good question. We do, for the right now in this initial beginning part, we just really want to get to where our services are accessible to the people who are using them. That's really what we're trying to just kick out and really need support in right now. And like, honestly, people are scared. We'll have somebody come and they'll say that, they're the only one from their group of friends, and their group of friends are convinced that, they're scared. But we definitely, we're tracking everything. So like, overdoses that are reversed, people that do reach out for treatment services, all of that, we're keeping track of. And we just, in a nutshell, we want to be able to make recovery accessible and just services accessible to those that are falling through the cracks and not being served and aren't, are deemed unworthy of receiving those services. So we're trying to bring them to them. So that's kind of where we're at with that.
Mm-hmm. So I'm going to move us into inviting you all to ask any questions or share any thoughts you have with Allie and Riley and Brooke. As we do that, I think it's worth mentioning that kind of the unwritten code that I follow as project manager of Envision Athens is grace and truth. And it isn't really helpful to do community development work if you're lacking either of those things. So sometimes it's easy to just focus on what's going well, but if we don't tell the truth about what strategies save lives, then we are not doing our jobs, right? So you have my support in this, and I've also had conversations with some local elected officials who I know support harm reduction strategies. So I'm hoping that we can move into some more progress in this area. But what questions do you all have?
Well, I just saw a question in the chat about how many individuals are served. And that's a great question. And it's one that's changing very rapidly. I mean, we've been very careful and mindful to do everything above the table, everything. We're an LLC, we're licensed, insured, like everything is 100% legit. And it so depends. Like on Wednesdays have been really slow. We had a few Wednesdays in a row where no one came. Just this last Saturday, a few days ago, within an hour and 15 minutes, I served 11 people and distributed over 200 syringes, probably about 220. Oof, where's the funding come from? That's a huge one. We do not, like, we are running 100% on donations right now, which is hard. And we're trying for grants. A lot of it is hard because we're so new. There's so many places that won't give money out to folks that like can't show the year in review. So we're busting our butt trying to do all that and to track everything really well. But the funding is hard because we're all volunteer based. It's really just the supplies. Like the supplies is the hard part, but it's more than just syringes too. Like we have cottons, cookers, water, tourniquets. I mean, and we educate them, like, because it's not just the syringe itself. It's, because everyone can have their own syringe, but if they're all dipping it in the same spoon or cooker, like it's pointless. So we distribute all of that.
So Riley, connected to a question in the chat box, I'm going to make a request of you. I think if you all could create, and you may already have this ready to go, like a one-pager describing what you're doing, and actually maybe saying, I found it really effective in my fundraising days to connect, like, this number of dollars means this much. And based on the cost of some of the items, your ROI or return on investment is incredibly strong. I would be happy to do what I can to help connect you to some additional funding resources. So, and I heard that you have a link to donate on the website, which is really key.
Yeah,
That'd be
and we
great.
have, I mean, you can donate through credit cards, PayPal, Facebook. We have a Facebook page also. We try to make it as easy as we can for donations. But we're, real talk, we're stumbling through the beginning of all of this, We're crossing our fingers we'll get some grant money, especially as like the work that we're doing is undeniable. Like there's undeniable change and growth that happens when doing this work. So more will be revealed, as they say.
Harm reduction reminds me a lot of Housing First, in that the reasons not to support it defy logic. The only reasons not to support it much more relate to the discomfort of the conversation and some other things. So yeah.
Well, and you were, like you said earlier, that this group had talked a lot about naloxone and medication assisted treatment. Those things are forms of harm reduction.
Yeah.
Housing First is a form of harm reduction. Harm reduction is a really big umbrella term. I mean, like in the days of COVID, our masks are harm reduction. We get in cars and we put on seatbelts. Like harm reduction is all over. But yeah, just the like reframe of people being deserving of services or people being deserving of housing, or, we struggle with that here. There's how, you can stay at the shelter only if you can screen, like leave a negative screen. There's one shelter that does that, and it's a barrier. It's a huge barrier, and a lot of people are there because of substance use or mental illness, and it's a barrier.
Guys, thank you so much. I'm going to move us on into a deep dive related to naloxone, if that's okay, unless anyone has an additional question specific to this presentation.
I saw one. Megan asked if, so as of right now, they come to us in the parking lot at Divas, but we are trying to start a day for mobile services. But again, though, saying that everything we're doing legally and legit, there's still stuff with DPH, with the Department of Public Health, and what mobile services look like. But we are trying to make this as accessible as possible. And we will have multiple sites in multiple parts of town, and we'll be doing mobile services for those who just can't get to us. So, yeah.
Great question. Okay. Thanks so much. Proud to support you guys. Thanks so much for what you're doing. So moving into the naloxone part of the harm reduction conversation, I just wanted to kind of open the floor for any updates you have. Look at that sweet baby. Sorry, that is worth stopping the meeting for. Congratulations to Michael Bean, new father. That is a gorgeous child. Naloxone. It has been a bit of a journey to try to discern what is the most strategic place to start and kind of use that as a potential positive leverage point to reach what I'm hoping is kind of a tipping point where naloxone is, as you all suggested months ago, is as available or as common in a public location as a first aid kit. And so we do have a downtown business owner who fully agreed to being trained in naloxone and making it available at his 4 locations, and then has completely gone off the grid since I last connected with him. So that's just the true story of what happened with that one contact. That is one of many potential partners. And so where I've made some movement recently is to follow up with a few folks. So I'm just going to run down this list, if it's okay with you guys, for the sake of our time, and then open the floor to any additional suggestions you have, as well as if you have specific connections that you're willing to lean in on to help increase naloxone availability. I welcome that and ask you to kind of join in that. So one, I know we don't have PLR or Advantage here today, as far as I can tell. But, is naloxone available at the Arch location off of North Avenue? I don't know if Michael can confirm that. I imagine it is in at least one component. So does PLR have it, Homeless Day Center, both? Do you know?
I'm almost certain I'm certain PLR does. I can't speak firsthand, but I'm certain they do. Homeless Day Service Center carries naloxone. All of our street outreach case managers also carry naloxone, and I believe they have them at some or most of the clinics in other counties.
Mm-hmm. Great. Okay. I thought that probably went without saying, but I think part of this conversation is just confirming that we know it's in certain locations already. We all know that police officers carry it, and EMTs have it on their person as well. I reached out to Salvation Army, Bigger Vision, and Athens Area Homeless Shelter to begin that conversation with them, as well as put a call into Downtown Ministries, which is now operating the Our Daily Bread program, which is, as many of you know, located at First Baptist. They have a weekday lunch program 5 days a week. And so I think those are also Logical locations, again, just the starting point. Then there's the question of UGA. I spoke with Dan Silk this morning, who is the chief of police for UGA police. He's a phenomenal human. And as I suspected, he confirmed that naloxone is of course carried by all of his officers, and they've had great success in being able to arrive at the scene in time to utilize naloxone as it's intended. Some other opportunities that we considered just in brainstorming would be to connect with the Panhellenic Council to advocate for naloxone in the Greek houses. Of course, I recognize, and I think everybody on this conversation or call recognizes that the how of this conversation is maybe more important than the what, because if you don't do the how well, you don't get to the what. If people feel like you're insinuating that that their location is like prime, then that can be a conversation stopper. So I think what is necessary is kind of following the lead that you guys provided, Riley, Allie, Brooke, is acknowledging that this is part of our reality. And so instead of making this a judgment laden conversation, trying to just acknowledge this is part of what happens. And we're not handpicking certain locations. You know, today we're starting with a short list because we have to start somewhere. But the way I think it might be helpful to communicate is to acknowledge that this is a wide-reaching reality, unfortunately. So those are my ideas. This is where we are now. I'm going to stop talking and invite you to give me some guidance or alternative ideas.
I think right now, let's see. It's just real that we're kind of rounding this corner. That works. So I think folks are scared about that.
Hey, Allie, can you hear me? There you go. Let's try again.
Can you hear me better now?
Yes.
So I think that with COVID, it's just gotten extremely tricky. Once we finally thought, I think, was it June, July, we were kind of rounding a corner. We thought maybe we could slowly get out in the community. And then all of a sudden it got a lot worse. So I think folks are scared to have people, you know, get in a group and be trained. However, we have tons of naloxone just kind of waiting for a safe opportunity. We have a ton of IM kits from Georgia Overdose Prevention, which are the injectable kits. Very easy, not very scary. So we're happy to do that kind of training. We just have to make sure that it's safe. But just know that we do have quite a lot of supply. So we're just waiting for an opportunity.
I appreciate that. And that, I mean, that's kind of a good problem to have, right? We actually have supply and I believe there's demand. It's just a matter of connecting those. I would love your thoughts, Judges Auslander or Sweat, based on your wisdom and experience. Do you have any thoughts about this?
I'm afraid I don't have enough context to what might be currently going on. If you were trying to reach out to like Ms. Grant or someone in probation, because most of this court supervision is abstinence based, it might not be a good fit. Although many, of the individuals that are being supervised are continuing to use and at risk, but I'm not sure how to resolve the tension between those two things. Chuck, do you have any ideas?
We've trained, I think probation has been trained, I think almost all of them have gone to the training. I've had the people on my team trained, and my supervising officer coordinator and our counselors all have naloxone for the purpose. But it probably wouldn't be a bad idea for us to kind of among the local, just find out who's new and who hasn't had the training, because we actually could provide a safe space, and we have people that are coming into contact every day that could use it. So I could definitely survey around the courthouse and ask the judges if their coordinators and supervising officers have.
Mhm.
Glad to hear that, Chuck. I was not aware. Thank you.
I'm glad I asked. That's very encouraging, Judge Oslander. Yeah, thank you so much.
I think Dale brought that.
Okay, I just want to jump in.
Oh, Raleigh, yeah, go ahead. I think you're lagging a little bit.
I just wanted to like, oh, I'll turn that off just in case. Is that better? Excellent. Just by means of numbers and efficacy of who naloxone is distributed to, the most effective people, like the people who use it the most, are actually active users or family and friends of active users, or those of us working with active users. What gets really hard is, like, it would be beautiful if there was a space that was created where in abstinence-based programs, it would still be okay that they could have naloxone distributed to them. I think what happens is that thing of like, oh, if we do this, are we giving them permission to use? Or that, like, you know, if we give kids condoms, are they going to have more sex? Like, it's that, I think that's some of the controversy or what makes it difficult. But those, I mean, especially people in early abstinence-based recovery, if they are to have a slip, those are at the very top of the list of like potential overdose, like fatal overdose. So, I mean, if we can get that in any of those hands, it would be great. And we absolutely can do education with that also. Just want to throw that in there.
Thanks, Riley. Oh, yeah, gotcha. Judge Oslander, were you about to say something additional?
No, I was just saying that was something that Dale did at one point, was allow the probation to go to the trainings, I think at the police department. And so that's where our supervising officer, I mean, obviously some of the ripples of Dale continue through here. So, but I feel confident that the new chief of county probation, to the extent that any officer isn't trained, would be committed to having all their officers trained and carry it on them at all times.
And
Great.
I just want to say that my office did have, I think, more than one naloxone training for our active users. However, it's just a problem with getting groups of people together at this point. And I'm individually, as people are taking me up on it, I'm having them watch a training video and handing them the kits that are left over from that. But, it's getting people in a group, that's a problem right now. And it's also sometimes having people actually admit that there's a good probability that I am going to pick back up again, even though I'm going to stay clean. I'm telling you, I'm going to stay clean for my daughter this week. So.
Does anyone have thoughts on how to overcome the hurdle of training more people in a space with social distancing?
Aaron, we trained up the members of my street outreach team, and it was a small scale. I think about 8 or 9 people attended, and we did it virtually, just like a video meeting like we're doing now. And for my untrained eye, I didn't see any any shortcomings doing it in that method, and then did kind of a safe distribution after the video training. I'd like to hear the comments from the people in this room, or see if you have any criticisms of that method.
I can't speak for everybody, but in my virtual work over the past, however, 8-9 months, it's kind of, I don't know, access to technology is not always there. And we have an awful lot of connectivity issues, a lot of people that don't know how to access things online. And so I feel like sometimes we miss out on the most high risk people that way.
Yeah, I really picture this model as a way to connect with other organizations or service providers or local businesses who do have access to that. But yeah, that is a huge barrier for the end user. I agree.
Well, and I think one level or layer of this conversation that we're at right now seems to be a little bit more focused on service providers. And I think that makes a lot of sense and is a great starting point. Correct me if I'm wrong. Is it not maybe even more strategic or to the point to work with service providers to have on-site trainings for everyday people? So for instance, like one layer of this would be to train the Our Daily Bread kitchen manager and have naloxone on site. The next level would be to have a training on site and distribute naloxone to the guests or participants of the program. Riley, I think you're there to speak.
Yes. I hate it that this is true, but I think that education almost has to go along with it because there are so many agencies, like Salvation Army in Gainesville. They had 2 overdoses in 1 week and they had naloxone on site, but they weren't allowed to use it. So like we can distribute it as much as we can, but there are still agencies that from a higher level, like the people can't use, which is just mind blowing. So I don't know. I don't know what to do there except offer education.
Okay, sorry. So if you can see my face, you could see my eyebrows furrow, which I'm trying to work on, but sometimes you can read my face really well. Just so you're saying that naloxone was available, overdoses occurred, people died, and even though the reversal opportunity was present, it was against organizational policy, or what prevented them from applying it?
The overdoses occurred on site. They didn't die because the EMTs got there in time. I think one was an EMT and one was an officer. So the overdoses were able to be reversed, but not by the staff on site who actually had it there, which is mind blowing. But
And is that because it was against their organization's policy to use it?
Yes, exactly.
But why did they have it on site?
Just like this conversation, like, oh, we'll distribute it and we'll this, that, and the other, but at an organizational level, they weren't able to. And I know about this from being on email lists with other agencies and organizations that are doing this exact same thing, only at a state level. And that it came to our attention that Salvation Army in general are not allowed, like they literally can't touch someone or give them any form of medication, naloxone included, and apparently weren't willing to make
Exception?
Yes, make an exception for naloxone during an overdose.
Okay, well, I'm definitely interested in learning more about that. So I know we're closing toward the end of the hour. Riley, thank you a lot for that. That's disturbing and for sure something I'll follow up with you on offline. So again, I'm gonna just reiterate the list that I have here. And then would love to invite you if you have additional partners in mind, specifically if you have connections to business owners, and I know you do, so that's kind of rhetorical. Please share with me through email or the chat box what connections you're willing to make. But again, my list is UGA, SGA, Student Government, Panhellenic Council, Salvation Army, Bigger Vision, Athens Area Homeless Shelter. I'm also in touch with John Morris about the Backpack Project and Athens PBJs. Is there any other group that comes to mind?
I have a quick question about this. So I understand the primary goal. I'm wondering about some maybe sort of secondary goals, just as far as getting people more educated who can be advocates. I'm thinking about like I serve on a local school governance team. I'm also on the safety set. It's a juvenile justice organization. So maybe people who don't necessarily need the full training in how to administer it, but people who would be able to share information and really advocate for more
That's
education.
great, Megan. Yeah, we need champions, right? In order to, so there's the awareness and the application of. So that is a great point. We've talked about that in some past meetings, and that's definitely part of the follow-up strategy as well. I see we have Patrick Howard, who is, I believe, the new neighborhood leader. And so I'm in touch with that program, which connects to that safety strategic action team that you mentioned with Tim Johnson. So yeah, I would love to work with the neighborhood leaders since they are geographically distributed across Clark County to hopefully kind of mobilize their championship of naloxone, which could have a lot of impact. Yeah, that's great. Guys, we're running out of time. I don't want to rush us, but also don't want to keep you past the hour either. Any other ideas about that specific item before we kind of start toward closing out? Megan, I would love to follow up with you outside of this space to talk more about those strategies. And guys, this is only moving forward. I think if we help it move forward. I feel like I am not one to use athletic illustrations. So I've used 2 so far today, which is really weird for me, but it's full court press time. So I'm ready for that. And I think you are too. One thing that I want to share with you is a job opportunity to join Ed's workplace. Ed Moore, one of our favorite colleagues with St. Mary's, they are looking for a community health worker. I've shared this with a couple of really strong candidates today. If you know of anyone who is qualified to do that work and interested, please pass it on to them. John, will you shout out our next meeting? And then if it's okay, I'm going to close this out with a thought.
Sure. Our next meeting is on January the 13th at 10 a.m. That is a Wednesday morning per our usual time, and that will go out in the meeting email with the notes after this meeting.
So guys, I'm going to close this out with this thought, and I do apologize. We didn't have as much time as we normally do to hear your updates. So please, in response to the notes, if you have anything that you want to share with the group, let John or I know, or if it's something of general interest, respond to the group. I'm going to close this out with this. This was in my daily reading. And, I woke up today thinking about this harm reduction conversation. And so this quote is going to close our meeting, and it comes from Jean Vanier, who, if you know anything about La Arch communities, they are all about full inclusion of people of all abilities. And so he said this: to love someone is not, first of all, to do things for them, but to reveal to them their beauty and value, to say to them through our attitude, you are beautiful, you are important, I trust you, you can trust yourself. We all know well that we can do things for others and in the process crush them, making them feel that they are incapable of doing things by themselves. To love someone is to reveal to them their capacities for life and the light that is shining in them. So thank you. You guys are making this true for me in so many ways. I appreciate and care for every one of you. Have a wonderful holiday season, and I will see you on January 13th, if not before. Thank you.
Thank you. Have a good holiday. Congratulations, Michael.
Thank you, Judge Sweat. Thank you, everyone. Much love.